All right, I have what I think is a fairly interesting case for you. This case comes from Dr. John Witt. He's one of our residents at UTMC. He's from the University of Kentucky College of Medicine. Looked up his name. Variant of White, the Old English Whit evolved into White over time. Whit emerged as a distinct but relative surname. Witt family, record is Doomsday Book, okay, meaning wise man or counselor. The Old English for wait, to a place of ambush. Okay, so Dr. Witt is a wise man who's going to ambush you, so you can't trust him. Watch your back. Like, look at those beady eyes right there. Yeah, creeped out. All right, so here's the case. A 60-year-old male with a history of Alzheimer's, dementia, MI, TIA, hypertension, and hyperlipidemia who presents with syncope. Already, before we even look at the EKG, this is concerning, right? Like, this gentleman's high risk. Like, we know he has vascular problems. He's had an MI before, a TIA. He's got hypertension, hyperlipidemia, and he's 68. So high risk for issues, so let's look at his EKG. All right, here's the EKG. We have nothing old to compare to for this patient. So I recommend that you pause and go through it, but I'll go through it and we'll see what I think. So here's the rhythm strip down here at lead 2. I see 1 P for every QRS, so we're sinus. The rate looks normal to me. So for axis, AVF is down and lead 1 is up. So I'm going to say left axis deviation. For intervals, we definitely have a prolongation of the QRS. As far as the QTC goes, I'm not seeing overt signs of a prolongation. Here is kind of concerning. But again, I would defer to the machine for that. Okay, now let's look at our J points and ST waves. First of all, this T wave is flat/inverted in AVL, which is kind of concerning, but no significant J point deviation. Here in lead 1, we have a flat T wave, but no significant J point deviation. Here in lead 2, we do have a little bit of J point deviation and upright T wave, which is normal. Maybe a little bit of J point deviation in 3 with an upright T wave. J point deviation slightly in AVF with this biphasic T wave. We are one of our AVL. In AVR, remember to follow up where your J points are. Here's my clear J point. So here I'm not seeing much J point deviation and inverted AVR, T wave, and excuse me, AVR. Patrick coughs. Over here in V1, I'm not seeing much J point deviation, but an inverted T. Same issue here, not much J point deviation. This biphasic T wave, which is interesting. Not much J point deviation, biphasic T wave here. Same much, J points look good, T wave's okay, J point good T wave, J point good T wave. Okay, so overall, what we have here is a complete right bundle branch block because the QRS duration is over 120 and it's upright in precordial leads. Interestingly enough, though, we have an axis deviation. Okay, so anytime you see a right bundle branch block with an axis deviation, a huge red flag should go off for a fascicular block. Because this is the important point for right bundle branch blocks. Normally, a right bundle branch block does not have axis deviation. Okay, let me say that again. Normally, a right bundle branch block does not have axis deviation. Okay. Yes, there is usually an S wave in lead 1, but it's usually smaller than the R wave. So again, anytime you see an axis deviation that could tip you off for a fascicular block, and that's what we have here, okay? It's down in 2, 3 in AVF, up in 1 in AVL. So we have a complete right bundle branch block with a left anterior fascicular block. So we have a bifascicular block, okay? A couple things, again, for a right bundle branch block, remember slight ST depression or T wave inversions in the precordial leads can be normal, okay? This biphasic T wave here is interesting because it almost looks like a reverse Wellens. Wellens goes up and then goes down. This one goes down and then goes up. Oftentimes that's associated with hypokalemia. I do not believe this patient had issues with hypokalemia, but I would refer to Dr. Witt because I didn't get all of the labs and stuff. So the short of the story is this EKG shows a bifascicular block, okay? For me, bifascicular blocks are concerning in a couple of situations. Number one, when they're new onset and you have signs of chest pain or anginal equivalents, that's concerning for coronary disease and acute coronary syndrome. Number two, when you have syncope, whether the bifascicular block is new or old, okay? So those are the two issues where I get concerned about a bifascicular block. Like I said, number one, potential for coronary disease depends on your pretest probability. And number two, when you're having syncope, and that's what this patient presents for. Now, what does the literature show? So the literature does show that patients with bifascicular blocks and syncope do better with a pacemaker, okay? This case right here, pretty interesting. Okay, they compared pacemakers versus implantable cardiac monitoring. Interestingly, there was no change in syncope, but the people who had the pacemaker had a lot less, bad outcomes. And similar with this paper as well. In patients with unplanned syncope and bifascicular block, a pacemaker significantly reduced recurrent syncope and bradycardia without increasing evidence-related complications of cardiovascular mortality. So that's the summary for this case. Excuse me. Short of the story is bifascicular block, okay? When you have the short story is number one, okay? When you have a right bundle branch block with an axis deviation, then it's probably a bifascicular block, okay? Number two, bifascicular blocks are concerning in two instances. Number one, new onset with anginal or chest pain is concerning for ACS that needs to go to the cath lab. The other one is, syncope, whether new or old, with the bifascicular block. Those things are what need to be addressed by us in the emergency room. That's all I got for this case. I hope you enjoyed it. Until next time, Patrick is done talking.